students who have joined us from all over India. So without any further delay, I'll begin my talk on hemodialysis in special situations. I'll be covering hemodialysis in pregnancy, in cerebrovascular disease, in elderly geriatric patients, as well as a brief discussion on sarcopenic patients. So we all know that various causes of decreased fertility in end-stage renal patients are various, that reduced libido, reduced sexual function, menstrual disorders, various metabolic and biochemical derangements are there in our female patients who are on dialysis. Various pregnancy outcomes have been studied throughout the history on maternal as well as fetal outcomes. In brief, maternal outcomes are placental abruption, premature rupture of membranes, uncontrolled hypertension, worsening of original hypertension, preeclampsia, complicated by toxemias of pregnancies, further progression of the GFR decline, infections, and death, maternal deaths. Fetal outcomes, IUGR, low birth weight, small for gestational age, respiratory abnormalities, prolonged ICU stays, and neonatal death again. So for best outcomes, pregnancies should be planned in our MHD patients. Frequent counseling should be done while they are visiting us in the OPD. So if we take a look at the brief history of pregnancy and dialysis, first case report was published in 1965, where a 32-week pregnancy of a 33-year-old woman was reported. She was dialyzed 4 times a week, and she delivered within 3 weeks a viable infant. Similarly, a systematic review was done by Piccoli et al. In 2016, where he compared the pregnancies and reported more than 600 pregnancies, but again 88% of them were preterm in patients who were given dialysis. So according to USRDS, what they have found is that 27% of pregnancies result in live births in patients who are on maintenance hemodialysis. 3% still result in stillbirth, 29% are associated with spontaneous abortions, 8% go for therapeutic abortions, and various other like ectopic pregnancies are found in 3%. So what is the first step of management of a patient who is on dialysis and gets, pregnant? So first and foremost is always to refer them to a high-risk maternal fetal medicine unit. Intense counseling of the risk and benefits, which most of the times is missed by in the very heavy OPD setup that counseling is less focused upon. We have to tell them about the maternal and fetal outcomes, and we can give them an option to terminate or continue pregnancy. That is our duty to do so. So before discussing about dialysis, few like what medical optimization needs to be done. Various teratogenic medications need to be discontinued at least 6 weeks before planned conception. However, if it is an unplanned, stop as soon as immediately you have discovered about the pregnancy. So just a small list about various safe and unsafe medications: antihypertensives, labetalol, DHPs, methyl-topa, hydralazine. So now we come to our topic of what modifications are to be done on hemodialysis during pregnancy. What are the indications for starting dialysis? They are as similar to those in non-pregnant women. We have to outweigh the benefits of dialysis with the burdens and risks. Various indications: acidemia, bone mineral density disorders, anemia. We have to look for the residual renal function in our pregnant females. Volume management has to be taken into account, hypertension, as well as various uremic symptoms. We always try to, delay the need of dialysis. If the patient is not on dialysis yet, we try, but if it is inevitable, we have to start. And dialysis should be initiated if we are no longer able to manage all the complications medically. So this is a general dictum which is followed, that blood urea nitrogen more than 50 is associated with poorer fetal outcomes, and study done by SMI et al. Found that lower BUNs less than 48-49 are associated with good birth weight as well as gestational age of delivery. We have various modality choices. We can provide them in-center hemodialysis or home hemodialysis, peritoneal dialysis. All options should be given to the patient. And study by Shah et al. In 2019 reported that more patients were on hemodialysis than PD. So HD is still preferred by pregnant females because of various obvious reasons. We'll be focusing on hemodialysis. So we come to what should be the intensity of dialysis in these patients. Goal is always to reduce the interdialytic weight gain, intradialytic hypotension, uremic toxin buildup, as well as electrolyte derangements. So study which was done in 2014, where it was a comparison of Canadian and US cohorts was done from 2000 to 2013. The pre-kid Toronto group reported the dialysis intensity doing 6 to 8 hours each session for 6 to 7 days per week. They compared with the ARPD, that is American Registry for Pregnancy Patients, where 70 pregnancies were, of American pregnancies were compared. So they found that two groups were there, groups with less intense, where dialysis was given less than 20 hours per week. Live birth rates were associated with only 48%. However, the groups having more intense dialysis were given more than 36 hours per week, higher live birth rates of 85% were there. They were having longer gestational age, greater infant birth weight, as well as improved blood pressure and volume management. Similarly, a national survey was done by Sachdev Vital in 2017, where they reported that the routine prescription given by our physicians or nephrologists was a dialysis of 4 to 4.5 hours duration, 6 days a week, comprising about 23 plus minus 7 hours per week of total dialysis in a week. So what they concluded was that ideally we should change from a routine 3 days per week to a 6 days per week session, and increase the sessions from 3 to 3.5 to 4 to 5 hour sessions each for each session of dialysis. This was what they concluded. So KT by IV and urea levels are not ideally recommended to be followed in pregnancies, and pre-dialysis BUN levels of less than 50 are used as surrogate marker for dialysis efficiency based on various studies. If we go on for the modification of dialysis prescription, generally a low sodium dialysate is preferred. Low bicarbonate is preferred to avoid alkalemia, which is due to the respiratory alkalemia in pregnancy. Acetate dialysis is not recommended. Potassium is not to be kept below 3 milliequivalents per liter in pregnant females. Calcium has to be standard 2.5 milliequivalents per liter, because net positive calcium balance is required to meet the fetal requirements, as well as we there have placental production of calcitriol. So again, serum calcium levels have to be monitored to avoid hypercalcemia, so regular monitoring is very much required. For phosphorus, yes, we all know, it has been discussed, that as we have increased the duration as well as the frequency of dialysis, less needs of phosphate binders is there in pregnant females. If needed, then only calcium-based carbonate or calcium acetate should be used. And phosphate supplementation may sometimes be required, because we are giving such intense dialysis to our pregnant females. So now we come to how we monitor the weight gain and volume status in pregnant females. We know it is difficult because there is lack of urine output. The normal weight gain of pregnancy is about 1 kg in the first and second trimester, and then 2 kgs per month in the third trimester. So difficult to monitor whether the patient's actual weight is increasing or volume retention is there. Then we have to balance the risk of overhydration with the risk of critically lowering the placental flow. But there is always a challenge as to how to define dry weight in the pregnant females who are on dialysis. So there are various pros and cons of hemodialysis in pregnancy. Pros are, yes, there are less dietary restrictions, less water restriction, as well as less overload using the technique in pregnant females. But again, intermittent dialysis, if the patient is not going for 6 days a week, then less metabolic control, higher risk of hemodynamic instability, anticoagulation dialysis, as well as lesser autonomy in these patients. So apart from dialysis, various other issues while managing the dialysis are that we have to manage their anemia, which we all know the causes why pregnancies have anemia. So target level of hemoglobin in pregnancy is not clearly established, but erythropoietin use is to be continued during pregnancy, and empirically a 50% increase should be done of the erythropoietin dose, and the goal is 10 to 11 grams per deciliter. Iron, again, higher iron requirements are there, as well as the daily hemodialysis is increasing your iron losses, and high rate of transfer to the fetus, especially after 30 weeks is there. So we have to target the TSAT levels more than 20%, out of which 80 to 90% of the parental iron deposits are in the fetus. So FDA recommendation category B, ferric gluconate and iron sucrose. Less frequent allergic reactions have been reported to isomaltoside as well as carboxymaltose, but ferric gluconate are to be avoided. Folates, again, higher requirements, they have to be supplemented in pregnancy. Assessment of fetal well-being, this is a routine assessment that has to go on, which is done on non-dialysis dependent females also. And all these other things that have to be done are blood HCG levels are normally elevated in women with CKDs. So HCGs, higher HCGs may overestimate the risk of fetal abnormality. We have to keep that in mind. And stages with 3 to 5 CKD hypertension, we have to do more frequently the USG scans as well as Dopplers of the umbilical artery to look for toxemias of pregnancies too. So in short, the domain is anemia. We have to increase the erythropoietin dose by at least 50%, 10 to 11, hematocrit 30 to 35, TSAT more than 30%. For phosphorus and calcium, we have already discussed, we have to avoid hypocalcemia, hyperphosphatemia, we have to do weekly monitoring. We avoid hypercalcemia too. For acid-base disorders, we have to avoid acidosis as well as alkalosis, and we have to use a low bicarbonate dose in the dialysis. For nutrition, neglected part again, we have to do supplement with folic acid and B vitamins. We have to increase the protein intake up to 1.8 gram per kg per day in pregnancy, and we also have to increase the calorie intake. So now the hemodialysis duration, 24 to 36 hours per week, 5 to 7 sessions in a week with increased duration. Target blood urea nitrogen less than 50. Dry weight increased by 300 to 500 milligram weekly during second and third trimesters. We have to minimize the use of heparin as well as other coumarin and to use the biocompatible membranes. We have to avoid hypokalemia and keep the potassium dialysate level take up to 3. Target BP levels are 140, 120, 70, 90 as per the routine guidelines. We have to do the volume monitoring. We have to avoid ACE inhibitors and minoxidil antihypertensives. So AV fistula is the first choice of dialysis access, but if not, then AV grafts, which can be early cannulated, should be used. Otherwise, the last option and not preferred are hemodialysis catheters, but very routinely used in Indian practice because of poor management and less agreement by the patients to develop AV fistulas early. We have to plan elective deliveries by around 37 weeks because after this, continuing pregnancy is less beneficial and risks are high. But the decision of induction of labor or cesarean is as per the obstetrician. So in a nutshell, hemodialysis prescription during pregnancy changes. We have to go for intensive hemodialysis, increase the frequency, 4 to 6 sessions, 4 to 6 hours per week. We have to target a blood urea nitrogen less than 50 milligram per deciliter. Potassium is up to 3, bicarbonate is low, calcium is standard 2.5 milliequivalents per liter. We have to use biocompatible dialyzers, single use preferably. We have to increase the dry weight by up to 0.5 kgs per week in the second and third trimesters. Again, nocturnal hemodialysis option that can be given to the patient. Give them low dose aspirin, which has to be started at 12 weeks of gestation, increase the calorie as well as protein intake. So coming to the next topic, that is hemodialysis in cerebrovascular diseases. So we know that CKD and the cerebrovascular disease burden is very high, and because CKD itself is an independent risk factor for CVD. And stroke risk increases stepwise with the declining kidney function, elevating from 3.3 to 7.14 from CKD stage 3 to 5D as compared to general population. Other risk factors of stroke, proteinuria, atrial fibrillation, more commonly in geriatric patients. Mostly these patients are vulnerable in the 30 days before and after the dialysis initiation, with 3-fold increase in the risk of various types of cerebrovascular accidents, stroke, TIA, or another recurrent stroke. So these are the traditional and non-traditional risk factors of stroke. We will come to the management of acute ischemic stroke management point-wise as per the AHA-SA guidelines. In short, that the blood pressure targets should be less than 185. This is ischemic stroke first we are talking, not the hemorrhagic stroke. So BP targets are according to the AHA guidelines, and presence of CKD or 5D should not modify these targets. We have to give them high-dose aspirin therapy, only not to be given if it is hemorrhagic stroke. IV thrombolysis is as per indications. Dialysis dependency or CKD will not alter this management. Mechanical thrombectomy as and when required. If it is a large vessel occlusive stroke, decompressive craniotomy as decided by the neurologist, as well as patients are to be admitted in the acute stroke unit. While in the hemorrhagic stroke, we have to go for early intensive blood pressure lowering. Less than 140 is the target within 1 hour. It is safe and effective. Anticoagulation reversal, patients with CKD or on dialysis should receive reversal agents for vitamin K as well as non-vitamin K antagonists. That is very important for you to keep in mind. Idursulfimab is safe for the use in impaired renal function. We have to go for surgical evacuation of hematoma where indicated, as well as patients should be admitted in stroke unit. So what are the challenges in hemodialysis while managing a patient with acute brain injury? We know that there is a risk of increased intracranial pressure because of rise in the brain water content due to a reverse osmotic shift. This worsens or causes subclinical cerebral edema. There is a risk for penumbra extension if there are intense BP or volume fluctuations during dialysis because of reduction in the cerebral blood flow, which increases the area of your ischemic injury. Again, there is a risk of hemorrhagic transformation or herniation because of the anticoagulation which is prescribed in the hemodialysis. So various considerations that we have to do in the management of stroke in the patients of dialysis is that we have to, if the patient has developed stroke and is admitted with you in the stroke unit, we have to time the dialysis sessions with other essential rehabilitation services. We have to consider delaying the dialysis initial periods if patient is particularly at the risk of rise in the intracranial pressure. If we have to go, then CRRT, continuous veno-venous hemodiafiltration, is the treatment of choice if they have raised ICP. PD patients, yes, we generally avoid because of the large hypertonic large solutions which are required. We should give them shorter dialysis sessions if we are not able to give them CRRT to avoid various large fluctuations in the volume, hemodynamic instabilities. We have to go for gentle fluid removal, not intensive. Excessive ultrafiltration is to be done to maintain the arterial blood pressure as well as the cerebral perfusion. We have to exercise our caution with use of anticoagulation in patients with ischemic stroke as well as with intracranial hemorrhages. So modify the dialysis to minimize large fluid and BP fluctuations, consider CRRT, avoid large hemodynamic shifts, and start blood flow slowly and increase gradually. So these are prevention medications before, while the patients with all the risk factors is with you, that we have to maintain their BP targets less than 120/80, use RAS inhibitors, start them on antiplatelet therapies if the patient had history of stroke. ATTACK trial ongoing, which is to clarify the role of aspirin. There is a role in primary prevention. We can use the non-vitamin K oral anticoagulants in these patients, but more trial is needed in advanced CKD patients. Again, statins are, KDIGO recommends starting a statin, if the patient is more than 50-year-old. Carotid interventions can be done. For these patients, takeaway is that CKD significantly complicates all the phases of your cerebrovascular disease, from risk to acute management. We have to use it is a multi-targeted therapy. We have to go for traditional, the risk factors of traditional hypertension, atrial fibrillation, as well as uremia inflammation in CKD patients, make them more prone to stroke. And it is on dialysis or a CKD, then it is not a barrier to the routine management of stroke as prescribed by ASAHA guidelines. So this is a topic, dialysis in malnourished, where dialysis itself, our patients are more commonly come on dialysis. So it's a biphasic relationship. Sarcopenia, sarcopenic patients are more challenging to be managed on dialysis. Self predisposes them to malnutrition and sarcopenia. We will not be discussing that, that is a separate topic. But in short, sarcopenia is progressive loss of muscle mass, strength, function, and impairs the quality of life in our patients, leads to various complications, falls, hospitalization, and morbidities and mortalities. So it is more prevalent in our dialysis patients, 25 to 28%. Severe sarcopenia is also 26% in dialysis patients, and malnutrition, inflammation itself is a higher risk factor for cardiovascular risk and all-risk mortality. Various pathogenesis for sarcopenia are there in PD and hemodialysis. Assessment, anthropometric measurements, as we were discussing in the panel discussion, that SGAs should be routinely done but is severely neglected in our day-to-day practice. So therapeutic strategies to these patients who are on dialysis, what can be done not just on dialysis, not modification of dialysis, but a routine practice that should be employed is that we should encourage them to do any form of physical exercise, which is very important for them to maintain and improving the strength, muscle mass, as well as physical function. Intra-dialytic exercise is very important. I'll not be discussing what all can be done, but you can go and read various types of intra-dialytic exercises that can be taught them to do. These are very practical solutions for maintaining the muscle mass and strength. Nutritional interventions, tailored dietary interventions have to be taken. Supplementation of L-carnitine can be done. It improves muscle strength, but there is no good evidence on muscle mass. It is inconclusive. Various pharmacological treatments, ARBs, myostatin pathway inhibitors, as well as anabolic steroids can be tried to stimulate the muscle growth. So while the patients are on hemodialysis or peritoneal dialysis, the patients who are on hemodialysis can be given various nutrition supplements, enteral nutrition, parenteral nutrition, total parenteral nutrition, all these with amino acids related our dialysis solutions, PD, as well as in hemodialysis, infusions can be given to these patients to maintain the nutrition status. Vitamin D analogs, various pharmacological interventions can be done, myostatin we have described, and physical exercise remains the most important parameter. So sarcopenia is a complication of hemodialysis malnutrition, and it requires a multidisciplinary approach for management. Now we come to dialysis in elderly or geriatric population. So geriatric patients, mostly more than 80, dialysis is never the first choice that is taken by those patients. So we have to explain them conservative kidney management option also, whether they want to opt for that or not. That is a shared decision making that you and your patient have to take, as well as their attendants have to take together. Dialysis likely improves the quality of life and longevity, but if the patient does not want to go for the burdens, we have to take into account of the patient's logistics also, and how much the burden the patient and the attendants can bear. If you yourself find that dialysis is unlikely to improve quality as well as longevity because the patient has n number of other comorbidities like irrecoverable cancer or cardiovascular status is very poor, then conservative kidney management can be advised for. So what are the advantages of hemodialysis in elderly? Hemodialysis, we are not talking about peritoneal or other. So the procedure is easily done as it is done by trained staff, reduced involvement of the patient himself or the attendants. As the patient attendants are regularly visiting the medical facility, they can discuss various other issues with the medical personnel. Hemodialysis, yes, there is superior removal of waste products if a good efficient dialysis is being given, and less time is required for treatment sessions as compared to home hemodialysis choice if the patient opts for. But elderly have a particular disadvantage of vascular access, and complications are more in those patients. Higher hemodynamic instability, cardiac issues and cardiac abnormalities like myocardial stunning and new onset arrhythmias are more in elderly patients. Logistic and transport is particularly to be discussed with frail patients. So the first point is vascular access that we have to choose for the elderly, which is a very complicated issue. We have to assess for the vascular anatomy as well as the physical examination, clinical examination, as well as the Doppler examination. The physical clinical examination being mostly neglected nowadays, not routinely, strictly done by our students, which has to be emphasized and remains the most important thing in planning for a good, and as well as the outcome depends on this clinical examination. If by all the examination and analysis we find that survival is expected to be more than 1 year, then fistula remains the first choice. If we are planning for, if the patient has overall survival of the patient is not expected to be more than 1 year, and the vascular anatomy is very poor, then we can try for graft, otherwise the central venous catheters remain the first choice. If the overall patient's functional status is very poor, higher risk of comorbidities, and poor survival is expected, then it is a choice, whatever you want to go, central venous catheters, fistulas will less possible, and graft are also associated with higher inflammation in these old patients. So what is the status of fistula first initiative in elderly and the concerns that we are not able to achieve it? They have poor vascular health, atherosclerosis rates are high, the vessel elasticity is poor, they generally have diabetes, hypertension. So all these risk factors, they complicate surgical creation of vascular access, they increase the primary failure rates as well as they prolong the maturation times of our fistulas. These all risk factors and the outcomes lead to higher catheter dependence in our patients for the first 6 months. Still, grafts can be tried because they have quicker maturation and higher initial success rates, and they are a viable alternative for our elderly patients. We can do a thorough pre-surgical mapping of the upper limb vascular anatomy, a good surgical expertise in fistula creation, and we can develop an end-stage kidney disease life plan according to 2019 KEDOCI guidelines that vascular access plan must be individualized according to the patient's specific needs. So what are the dialysis targets in elderly and concept of role of incremental dialysis in them? So traditional targets like specific KT/V are not suitable for our elderly patients. They have low muscle mass, they have reduced physical activity and higher comorbidities. So we have to adjust the targets in these patients and focus on quality of life and symptom management rather than stringent biochemical goals achievement. We have to go for less aggressive fluid removal, avoid intradialytic hypotension. We have to achieve solute clearance, and we have to focus on preserving the residual renal function if it is still there. We can start with fewer sessions per week and gradually increase their frequency. We maintain the residual renal function. It reduces the cardiovascular events and mortality as seen in the recent systematic review done in 2024. So while these patients are on dialysis, the cognitive dysfunction is also a very important factor that has to be considered in the elderly. If it is there and if it is progressing, it can predispose to lack of adherence to the various chemical regimens, medical regimens. They can't make informed decisions if their cognitive function is declining, and their overall participation in healthcare management also decreases. And hemodialysis is associated with increased ischemic injury because of frequent episodes of intradialytic hypotension. Lastly, when do we have to consider to withdraw these patients from dialysis? It's not like till the last stage we have to go on. We have to do a periodic assessment of these patients, their functional status, frailty, and other comorbidities. If there is no improvement in quality of life, if there is severe, irreversible physical or physiological suffering, psychological suffering, other than end-stage renal disease, he or she has cancer, decompensated liver, heart disease, or poor neurological status, or if it is the patient's choice, then again shared decision-making network comes into place and you have to decide whether to stop the dialysis. You can continue conservative kidney management, other supportive therapies to prevent pain and other symptomatic management has to be given. Emotional and spiritual support has to be given to these patients, and bereavement regimens have to be given to the caregivers. So it is a multifaceted area of management of dialysis in elderly and requires a nuanced approach that goes beyond your traditional survival metrics.